commending the organizers of this conference, I think it's important to also acknowledge that being a pathfinder has never been easy. So we appreciate you. The theme of this year's conference is time to focus on quality in healthcare, improving outcomes. This is a global theme, has become very, very topical for the simple reason that since the days of Health for All by the year 2000, which is, by the way, universal health coverage, and the Alma Ata Declaration, we've all been talking about access and affordability. And in spite of all the resources we've thrown at access, in spite of the policy that we have developed, we find that we haven't made as much progress as we had anticipated or had planned. And so it becomes important to ask ourselves why. How come progress has been so slow in coming? And I think that's where the issue of quality has become critical. So we're asking ourselves, you've treated somebody who is supposed to get well, and the person doesn't get well. So what's the problem? Is it possible that we actually didn't treat the person because the quality was inappropriate? So while I do not wish to digress from the reason of my invitation, I think I must make a few background comments. So I respectfully crave your indulgence to please share some of the following information with me. Number one, that 10 to 15% of all deaths in low and middle income countries have been as a consequence of poor quality of health care. Those are internationally verified data. An approximated population of 8.6 million people in low middle income countries die each year from inadequate access to quality care. Out of that 8.6 million, about 3.5 million, 3.6 never got any health service at all. And then 5 million died because of poor quality. Some hospitals and facilities across all tiers of the health system remain unsafe, unfortunately. So if I leave my village or my house to go to a hospital with the expectation that I will get better, I find myself in an unsafe environment. How so sad. I've had a personal experience, and I'm going to say that towards the end of my discussion. And we also know that there are about 134 million adverse events resulting in 2.5 million deaths annually in low middle income countries. Of course, the issue of non-communicable diseases are incredible. 66% of maternal deaths globally are avoidable and primarily due to poor quality, as well as a 50% of children under age 5 and 38% of neonatal deaths are due to poor quality health care. It is also reported that high quality health system can prevent 2.5 million deaths from cardiovascular diseases alone, 1 million newborn deaths, 900,000 deaths from tuberculosis, and half of all maternal deaths each year. So I want to congratulate the Future of Health Conference organizers for choosing this topic because it's just so key. Now, these statistics that I've reeled out are from low and middle income countries, and my work is not in a low middle income setting. It is in fragile, conflict, and violent settings. So if you extrapolate that to such settings, you can see that we really, really do have a problem. So the situation is worse because in these settings, there are conflicts, there are wars, there are natural disasters where the health systems are hit by increased damage, in addition to reduction of resources You know, when I went to work in the northeast of Nigeria, I realized that we had a real problem on our hands because over 30% of the health facilities had been destroyed, and another 30% were partially destroyed. And almost all the healthcare workers had been either displaced or their services disrupted. So that's the environment where we are working in. I came to humanitarian work with a development background. I had been the Director of Health Planning Research and Statistics in the Federal Ministry of Health. Before then, I was Director of International Cooperation and International Health, and then Head of MDGs and Resource Mobilization. So for me, it was an exciting opportunity to go and now be in the field and practice all the policies one has helped to develop through the years. I think I'm still excited about that, but I'm also very sobered by the reality on ground. The reality on ground is that so much needs to happen beyond the health sector. So much needs to happen. It has been a remarkable experience for me, no doubt. But one thing I have come out from this experience with is that health is at the heart of development and humanitarian action. No matter what else we say, if this building collapses, for instance, God forbid, and there's nobody here, it will just make a little headline, right? But if this building collapses with all of us inside, so what do you think will happen? Just show me a sign. It will be a real calamity. So health is at the heart of development and every humanitarian action. And that's why we must take this conference very seriously. So our primary goals as custodians of the health sector within this context, therefore, is to, one, anticipate, prevent occurrence, and halt or curb the incident. Okay? And in order to maintain quality, therefore, I'm now taking you to my work in the Northeast. We had developed a strategic plan, and that strategic plan formed the bedrock of the Buhari plan for the health sector. So all through the years, through the 3.5 years that we've worked on this, we have been able to support the protection of public health, support refugees and migrants, and with the immediate quality health care, in addition to emergency services and screening services as they arrive into our shores. I think the people in public health emergencies will appreciate what it means to protect public health. We have collaborated with NCDC and NEMA and all the other agencies to look at the issues of flood and other natural disasters as they affect our public health. We've also established the health and nutrition emergency response in Borno, in the Northeast, and specifically in Borno State. And what did we do with those services? We provided essential services to the affected population. We also tried to strengthen the health system. And the plan is to ensure that we expand to all the 6 states in the Northeast and then expand humanitarian health action beyond the Northeast, because we have a lot of problems in the Northwest and several regions in the country. And for the health and nutrition emergency response in Borno State, the government has invested since 2016, December 2016, over 5.7 billion naira. To ensure that we provide emergency and humanitarian and now development health to the people in that region. What did we do? We provided essential health commodities and supplies. We also have maintained 350 health workers for these 3 years in Borno State. What does that mean? How does that work? What we've done is to have 33 teams of 10 health workers per team who provide quality health service for all the LGAs, in addition to extra sites in the highly populated LGS like the Maiduguri metropolis and all of that, where you have more internally displaced persons moving into them. For each of those teams, we have a doctor, a pharmacist, a nurse, 2 midwives, 1 nutritionist, 1 lab scientist, 1 health records officer, and 2 community health extension workers. And we have trained them in the package of humanitarian health in emergencies, including protection for themselves, because we don't want to lose our health workers. In this period, we've treated over 14,500 internally displaced persons, in addition to over 1.5 million persons residing within the host communities. In Maiduguri, in Borno State, this project has brought unprecedented support. Some local governments in Borno State have never had a doctor at all. So this project has ensured that we have doctors working in those LGAs. We also have logistics support with trucks, pickups, and all of that. And of course, the issue of strengthening coordination. Some of these critical success factors have been the availability of the skilled health workers, and also the availability of working equipment and supplies. And then there's the issue of perception. We have worked very well with the communities. We actually have mayors who are champions or ambassadors on this project, who own them and work with the people to ensure that they feel part of it. We have constant supervision and feedback mechanism, and it's not from just our own Ministry of Health source, but also from CSOs who do unannounced supervision. I mean, if I'm going to go to Maiduguri, everybody knows that Dr. Azodoh is coming. So even if you are not at site, you will quickly go back to site. But the CSOs ensure that they have, they're in the community, they have unsupervised, unannounced supervision and all of that. And we have accountability roles for the traditional and religious leaders. We're not yet there. There are challenges, and a number of the challenges are routine with the health sector, but the issue of coordination is primary. There's also the need for collaboration and consistent, sustainable financing. What we are doing is not sustainable. What we are doing is not sustainable. We cannot pay people on an ad hoc level, in an ad hoc system for too long a time. And if we have to go beyond the Northeast, it becomes almost impossible to do that. And so we are exploring other options, working with National Health Insurance Scheme, for instance. How can we support some of these, pay for some of these services? We're also exploring partnerships with NYC, with universities, and all of that to see how we can have redundant but skilled staff deployed to these kinds of intervention, especially at a time when they are not very busy. I had to present this at the WHO at a side event during the World Health Assembly, and it was well taken. So arising from some of our conclusions, we also have the National Council on Health pass a resolution in September, looking at how we can further strengthen our partnerships with our various stakeholders. And so, but I think I have a word for Future of Health Conference organizers. One, today is the tomorrow we were dreaming of in 2015. I'm sure we all look forward to 2015, that 2019 or 2020. Well, here we are. The tomorrow has come. And that tomorrow we keep coming will be a 2020, a 2025. And so it's important to ask ourselves, how have we maximized the beauty of the disruptions of technology? I have a son who is an IT guru and who has done well, just disrupting technology. So such language is something I'm very familiar with. He happened to have, also earned as the class of 2019 30 under 30 for Africa. So they keep disrupting this technology. But we ask ourselves, we've had the ICT for health, so how well have we done? What are we doing with artificial education, intelligence, education, the movement, international movement, and all of that, in order to maximize our resources, including the diaspora power, to help improve the business of health and qualitative outcomes. We've done well, but we can do better. So let's clap for you first. Then I'll tell you what I think we can do. One of the things I think we can do is to find a way to better mainstream the outcomes of this conference into the policy level of governance. And one of the suggestions, since you asked me to talk about my experience, one of the suggestions I can make is that we may want to go into a partnership with the Ministry of Health. I mean, I know the ministers are always here, but it shouldn't be difficult to get a partnership with the Ministry of Health. That requires a coordinating department to work with us here and take the outcome of this process to the National Council on Health. So once we get it to the National Council on Health, it will be passed as a resolution of the National Council on Health. We can also take it to Federal Executive Council if it becomes necessary. But once it's passed, it becomes mandatory, it becomes binding on all the states to at least do something about it. And so we can look at states like Lagos State to drive some of these processes. The other thing I want to suggest is to deepen the expansion of health beyond the regular health sector. You've done that already, but we need to engage more and more with the external determinants of health outcome. And there are so many of them. Ministry of Finance is critical, no matter what we say. And in this present dispensation, we have a Ministry of Finance who is also a Minister of Budget and National Planning. And so we must find a way to engage. So I believe that next year, when we come here, one of the key speakers will probably be from the Ministry of Finance or from all those other ministries within government whose action or inaction can determine the outcome or the quality of our health care much more than the Minister of Health sometimes. I think on that note, I want to thank you for your patience. Thank you very much, and God bless you very much.